Hello everyone and welcome to today's webinar, Trauma Verifications, February Q&A Web Conference. Please be sure to call in using your telephone by dialing in the phone number followed by the access code shown in the audio section of your webinar control panel or in the email invitation that you received for today's event. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Hi everyone, thank you for joining our web conference today, and I'm going to go ahead and get started. Here's our trauma program quality team. It's Tammy Morgan, myself, Julia, who's not available at the moment, and Rachel Sanchez. Just for everyone's information, our continuing education, to qualify, you must attend 15 minutes of this webinar, and an email will be sent to all attendees who qualify for CE within the next 24 hours after the webinar has ended, and how to obtain those CMEs will be provided in the email notification. And just a reminder, anyone who has any questions about the verification process, this webinar, or PRQ, please be sure to email us at the COT VRC inbox here noted on the webpage. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, and to understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your trauma center. So let's go ahead and get started. We're going to talk about some materials that you're going to need on hand. If you have a copy of the Orange Book, go ahead and feel free to follow us through this webinar. If you have a PDF copy, you can do the same. I also want to let you know that you must use the clarification document and the change log document that's on our webpage. We have those updated up through January, so those are very current. Another notice will be going out at the end of this week. Clarification, verification document updates, as I mentioned, be sure to use your change log and the clarification document in conjunction with the resources manual. As many of you know, any changes to the requirements will not be updated on the manual itself or the PDF copy. They'll be noted in the change log if it's related to a requirement, and if there's any clarification to any of our standards, it'll be noted in the clarification document. Again, this can be found on our resources webpage. The link's displayed here in the middle of the page. Just a copy of our clarification document and what that looks like. And this is a copy of our change log and what that looks like, and just want to let everyone know that this is an Excel file, and you can source this however you like, by CD, by level, and whether it's a new criteria or change or revised criteria. So again, it's an Excel file for your use. Recordings of our webinar will be posted on our resources webpage. They're noted towards the end of the webpage in case you can't locate it, so it'll be towards the bottom of the webpage. Our disclaimer, all questions are pulled directly from the questions that are submitted. There have been no edits made to the content. If your question is not answered in today's webinar, the question may require more information and will receive a response from the ACS staff within a week from this webinar. A couple of announcements I want to go through. Our next VRC Q&A webinar is scheduled for Friday, March 10th. The deadline to submit questions will be Thursday, March. That should probably be February. So we will go ahead and update that and send everyone an email about that. An announcement about our TQIP annual meeting. This is just a save the date reminder. It'll be November 11th through the 13th here in Chicago. So looking forward to seeing a lot of people in our hometown. And just want to let everyone know, stopthebleedcontrol.org is now live. If anyone's looking for any courses, they are now posted on our webpage, so feel free to go ahead and browse that webpage. And we're going to talk a little bit about the last call for TQIP. The next TQIP quarterly call for data is opened up February 1st. So we want you to submit your fourth quarter data, 2016, as well as any updates to previous submissions dating back to the third quarter of 2015. The call for data will close on Wednesday, March 1st, so that's coming up next week. And speaking of data.
Hi everyone, this is Tammy Morgan. I've been talking recently with our medical director of trauma quality programs, specifically about the data, the data that's used for our TQIP participation and benchmark reports. And we just kind of wanted to reach out to trauma program managers. I wanted to ask you, or just kind of put a seed out, plant a seed to ask you how engaged you are with your registry staff, if you are, following the Orange Book, and you're ultimately responsible for your trauma registry and the data that's in it, and for planning that data validation. And I know that a lot of times, because of staffing, that data validation is something that gets dropped sometimes. It's not real high on the list of priorities with everything else that you have to do in your busy day. I want to know if you hold your staff accountable to learning the new definitions each year, if you hold them accountable to reviewing the submission frequency reports and validator reports that are available to them as soon as they submit their data. You get those reports within about 5 or 10 minutes. They're ready and available for you to review, to check your data within about 10 minutes of data submission. And the reason why I'm asking you these questions is we've got some data problems. And one of the things that we have been trying to report back to you guys through the TQIP benchmark report is about blood products. And I know for level 3s, you are not, your centers do not yet have a process measure in the process measure section that you're capturing. That for 1s and 2s, but level 3s, don't stop listening, please, because I'm not going to. This is really about data, and it's about quality and about managing the data. And it is, if you don't, your benchmark report is only as good as the data that you give us, whether it's true and reliable and can you trust it. And you have to go through all the steps. And I preach this a lot in our TQIP Q&A and all at TQIP education for trauma registry staff, that it's something that you're ultimately responsible for. So for the past 4 years, have been trying to get data out of these blood products, and we've done things, we've changed them, we've clarified them in the definitions, we've slapped flags on them to prevent them from being answered incorrectly, and we still have bad data. 4 years later, we still have bad data. We put some process measure tools out there for registry staff to be able to look at to see how to answer the process measures if the patient meets the included criteria, and how to answer them if they don't. And it's just, I think, the case of not really looking at that whole definition, maybe understanding it, maybe knowing how to have the proper conversations with your vendor to make sure that your data is correct once it gets to you guys. And we've got that submission frequency report so you can see what your data looks like once you submit it, and to be able to tell, if there's something missing or not. And so I just wanted to I guess re-engage you in your data. I know what it's like for you. You wear a million hats to try to make your trauma programs running, but your registry staff are spending a lot of time to capture these fields, and they're just not getting across correctly. And sometimes it could be a mapping issue. We just can't tell from here. As I said, level 3s don't stop listening. I'm going to give you an example of something else that you may have seen changed over the years in the data dictionary, and that is a comorbid condition, obesity. That's another problem definition that we had. And the problem initially, that was just listed as a comorbid condition, and we asked you to report, in the back of the dictionary there is a further defined definition for what obesity is. And what we found in data validation and going to centers, that was typically just wrong. And when you would talk to the registry staff, they would say, well, it's documented as obesity, but without following the actual definition in the book. And the reason why I'm having this conversation with you today here is because of the data validation visits that I've gone to and over the years, whether it's myself or my data quality specialist, and sometimes we see very, very engaged trauma program managers, and sometimes we don't see them at all. They're not with us in the comparison review. They sometimes say things like, I am so busy and I have a registry person for that and I depend on them to take care of that. But, I think that it's important at least once a year when you get that data dictionary that you're all on the same page of what the documentation needs to be, what the data needs to be as far as reported to NTDB, and it's going to affect what you get back in your benchmark reports. And I hope you're using that. So, back to the obesity field, one of the things that you've seen over the years is this go from being a comorbid condition defined in our appendices to being cut to being height and weight data field that everybody fills out, and we did that because nobody was following the definition. So, okay, scratch comorbid condition. Let's just put a height and weight and we'll figure it out ourselves. And so now the problem we have with that is it's not being reported appropriately. You have to follow the criteria within the definition to report it. And so again, it's like another data field that your staff are spending a lot of time and money capturing, and it's just not being done right. So I just wanted to give a shout out to you to let you know that we are constantly trying to do what's best on our side for you to clarify the definitions. It's a big reason why we started piloting definitions before putting them out there in the data dictionary to hear from you. And so I just wanted to try to re-engage you if you're not already. If you're a program manager and right now in your head you're saying, I'm doing that already. Well, I'm not talking to you. I'm talking to those that aren't. So thank you for hearing me out, and I want to talk to you about one more thing. So we put out about a month ago the stakeholder public comment website. This is a survey for each chapter of the Orange Book that we would like to hear from our stakeholders, that's you, about each chapter. And no one knows, we know this book backwards and forwards, but nobody knows what it's like to live by this book better than you. And so if you would take the time to go to the website, and maybe, there's a lot of chapters, so I can understand if you can't do that all at one time. So let me give you a little bit more information. We've got this week, at the end of this week, this is I think actually it's Thursday, is, I hate to say deadline, because this is something that we want to be ongoing. We want you to, if you find an issue, whether we've revised a chapter or not, we want you to be able to go there and tell us, and we have a plan in place that we want to check that, keep that concurrent and check that periodically to see what your feedback is. But right now, our next chapter to be revised, it's actually the first chapter we're going to revise since the Orange Book was put out in 2014, is chapter 16, PIPs. And I don't know about you guys, but when I read that chapter, it kind of makes my head hurt. And so let us hear from you about that. So what's going on with us is we have an annual COT meeting where all of our surgeon committee members are coming together next week in DC, and we're going to meet. And so we're going to, one of our work groups is specifically about the revision of the Orange Book. And so we're going to take the information that we've gotten so far, and for 16, there's only been about 50 people that have filled out that survey. And I know there's a lot more than 50 people that have an opinion about Chapter 16. So if you could, if you have the time, please take the survey and let us gather some data and help these folks revise this chapter in a way that works best for you. And then I'll give you another hint. The next chapter I'm going to put out there, it might not be the next chapter that is revised, but there's a lot of things that have been changed since the Chapter 15 Trauma Registry was written. One of those is that AIS is now pass or fail. It's not just you take it and you get CE and you're good. And so we'll have to clarify that eventually. and we want the data to back it up. But the other thing is the volume per registrar criteria. What's changed about that is ICD-10 has come along. So if you're finding that, I've talked to many folks at different meetings I've been to that have told me things like, we were once concurrent and stayed concurrent until ICD-10, now we're behind. If that's happening to you, go in and give us some feedback on that chapter. If you would. Again, I appreciate you hearing me out. Just wanted to have a little chat with you, and I'm going to hand it back over to Molly.
And I also want to add, Tammy, for Chapter 16 revision, I want folks to realize, excuse me, is that a lot of the other chapters feed into Chapter 16.
Yeah.
So just don't think of Chapter 16, we're talking about everything relative to PI or, you know, CD 16-1, -2. Just keep in mind that a lot of the other chapters, Chapter 1, Chapter 2, whatever it may be, neurosurgery, orthopedic surgery, pediatrics, they all feed into Chapter 16. So keep that in mind when you're reviewing that and providing us some feedback. So, you know, it's okay if you're providing us feedback on Chapter 5 for the trauma surgeon, CME. You know, we're going to review all that information as a group.
Yes, absolutely, Molly. Molly is so right. And another thing, you know, even if you like Chapter 16, let us know it works for you.
Yeah.
You know, we want
Yeah.
positive, you know, the positives too. We just don't want to know what's wrong with it. So let us, we want to know what works and what doesn't.
Right.
All right. Thanks, guys.
Thank you, Tammy. Okay, we're going to go ahead and move into scheduling reminders with Rachel Sanchez.
Good afternoon. To start the process of scheduling a site visit, your center's application must be received in the ACS office at least 13 to 14 months in advance of your requested time frame or the current expiration date. And you can find that application right there on the bottom of the page. There's a link there. And since we receive a multitude of the applications, having it in this early will basically hold your spot in the time frame you're requesting. Plus, this also provides your center plenty of time to prepare and complete the online PRQ. And currently, all of 2017 through March 2018 has been closed to scheduling. So PRQ online access. After the VRC office receives your site visit application, the trauma program manager that is listed on the application will receive an email receipt acknowledging that we received it. And also very important, on this email receipt will be your logins for the online PRQ. So you have access to the PRQ at that point, right from the beginning. Site visit application payment. Okay, so please do not send in payment with your application. You'll receive an invoice 60 to 90 days before your visit, which will include the fees for both the site visit and TQIP. And then afterwards, your center will be invoiced annually for the quality program fee for the remainder of the verification cycle. This annual fee does not include fees for additional reviewers. So,
can I just add a quick thing? I know I've been seeing a lot of emails come through either to me personally or through the COT inbox about fees and what the fee is going to be for your trauma center. I just want to point everyone to visit the website. There's actually its own web page for site visit fees. There's a tab actually. There's an actual tab on the website that you can go and look at the next 3 years schedule of what your annual fee will be. And that fee does include TQIP and your annual verification / re-verification fee. So I just want to make sure folks were aware of that.
Yep, thank you. Thanks. Okay, so scheduling the site visit. You should receive your site visit dates by 90 days before your scheduled visit. Sometimes you'll receive these earlier, and on occasion it may be a little later because, and the reason for a little later is because sometimes at the end of the month, those last few are just a challenge to schedule with reviewers who have already been scheduled. And ideally, all the visits will occur during your requested time frame, and we'll touch on this a little bit more in a minute. During scheduling, when a lead reviewer is available for your visit, I'll contact the trauma program manager to confirm dates just to make sure they still work out. So there won't be no surprise dates. Okay, now this is a scheduling question. And the question is, what happens if a facility is due for a re-verification visit, but the visit can't be scheduled until after the due date? For example, the visit is due in April, but can't be scheduled until July due to difficulties on the part of the ACS, such as not enough reviewers or overbooked schedule. And then does the center remain verified past its due date? And how is that handled? And how long after the due date will the center remain verified? So if the center's application is turned in 13 to 14 months prior to the expiration date, as mentioned, ideally the visit will be scheduled within that time frame. And that's most of the time. However, in the rare occasion that it cannot be scheduled in that time frame due to a shortage of reviewers, we will continue to work on securing reviewers for this visit until a full team is secured. And it's typically scheduled like shortly after that, usually within 30 days. So, but now that I say it was rare, for example, this actually did happen to 2 centers just recently, and they were the last 2 visits of the month to be scheduled. Both centers were having a combined adult and peds visit, and both had March dates that had been set already. The teams were secured except for the peds reviewers because none of them were available. So I combed through the reviewers list and just asked them multiple times, just hoping that miraculously their schedule would open up and they'd be able to do the visit. But unfortunately, there were no reviewers available at that time. So we had to move the visits into April. Now, one of the centers is already scheduled in the first week, and they're set to go. And the other center is scheduled in the second week, and I'm still looking for one more reviewer. This time it's not a peds reviewer, but just to reiterate though, this rarely happens. And if either of these centers were due to expire before the visit takes place, this would not affect their verification status. In fact, they will remain verified until the final report is released. And this also does not affect their reporting year that is being used. We're aware of how much work goes into getting prepared for this visit, and so all of that will definitely remain the same.
Thank you, Rachel.
You're welcome.
So we're going to go ahead and begin with our general questions. And so we're going to start with a question from someone asking about the implementation of new standards. So a question came in about PTSD, and although there's not a new standard, it's actually a new section in our resources manual, and at this moment we do not have any plans to develop any deficiencies for PTSD. The question in the PRQ is just solely asking if the hospital screens or has a screening process for those patients that have PTSD, and it's a yes or no. So there's really no area in the PRQ to collect data so we can develop best practices. But this is a great, this is actually one of the perfect examples as to what Tammy and I were speaking to about the stakeholder public comment. You can give us feedback on things like this, whether or not you feel that it's important to have deficiencies or criteria around this, or maybe not. I mean, whatever comment you want to provide us, we're going to review those comments and build our revision process based off of that. Pediatric population. So I had a question about a trauma center who has, their state process recognizes that patients under the age of 18 are considered pediatric, and that's going to vary across many trauma centers. The ACS guidelines that you see in the resources manual for 15 years of age or younger, or under 15 years of age, is really for the purposes of completing the PRQ. So as you're completing the PRQ, all the data that we're asking you to collect for the pediatric, whether you're an adult trauma center treating injured children, or if you're a pediatric trauma center, the data we are collecting or wanting you to collect and provide us for a site visit are for those under the age of 15. Now, we don't want to discount those trauma patients that came in from 15 to 18, so We don't want data on that. What we do want to see is maybe a few cases, a few medical cases during your site visit process, and you can keep those in a separate section, like a different pile. So if there's any issue that may have resulted in a change in your PI process, we also want you to have that available at the time of the site visit. Again, you can have that on the side in a separate pile. Question about Appendix 2 about operative cases. So more than one procedure can be done on a PRQ, which is true. More than one procedure can be done. And the question is, are we asking for the number of OR cases or the number of procedures? And we're asking for the number of operative cases. I think the number would be too great to do if we were collecting it on procedure. Of course, you can have that information available on site in the event the reviewers will ask. But for purposes of the PRQ, we're just collecting OR cases. So I had a question about research. Reviewing research articles, what are the reviewers looking at when they come in and to review? And that is very reviewer specific. What the intent of the reviewers should be doing on a site visit is they're looking to ensure that the trauma center meets the research criteria. As you see here, and this is also on the what we're calling a summary form for research article, and it's also on our website. And this is for level 1. Let me clarify that. For level 1 trauma centers. So what the reviewers are really looking to see is that each research article meets the requirements. So that is whether or not it was approved within 36 months, ending from the last day of the visit of the reporting year for the upcoming visit, or ending the first day of the last site visit. So there's two options there. Was the subject matter related to the management of trauma patients, and was the work related to your trauma center, and was it authored or co-authored by the required disciplines, ortho, neuro, emergency medicine, acute care, etc. And I also want to state, it's not on the slide, but I do want to state that if you're working in a trauma system or consortium project, those do count. So I just want to make sure that is clear. Implementation of a criterion. If you have a deficiency in subspecialty coverage, how long should the deficiency be corrected prior to your verification visit? Great question. This will definitely vary based on the deficiency, but this is very specific to a subspecialty. So I don't know, it could be, you know, you just brought on a new ortho or a new neurosurgeon, and you know, we want to make sure that that neurosurgeon is compliant with all the standards. So we're asking somewhere between 6 to 9 months of documentation demonstrating the specialty requirement was implemented, and that process was monitored through the PIPS process. And again, the point of it is to ensure that the PIPS process is picking up any adverse outcomes, anything that needs to be addressed prior to the site visit. You don't want to try to implement a corrective action items a month before a site visit comes in, because the reviewers are going to take that to mean there's not enough data to ensure that that's been working for the trauma center. So I just want to make sure you're aware of that. I get this question often about isolated hip fractures and same level falls. And the question is, what is the orange citation in exact language for rule? I'm assuming this patient fall, only hip fracture, can admit to medicine without penalty. You know, the admission policy is going to be set by the trauma center, and this statement is you know, it's clear that we're going to get it. The admission policy for elderly patients with single-level falls and isolated hip fractures should be set by each individual trauma. We don't have any guidelines in the Orange Book about this, but this, you know, this is something the trauma center is going to set based on your local admission policy and your criteria. If those patients meet the NCDS inclusion criteria, and they should be captured in your trauma registry, and if the center includes them in the volume admission numbers for the PRQ, you know, we ask for the volume of your trauma center, then you must follow the rules of any other trauma admission, such as reviewing non-surgical admissions. So refer to page 121. There's a breakdown of what we are looking for your non-surgical admissions. So if you admit them to medicine and you have a surgical consult, that's going to fall under your non-surgical admissions because, you know, surgery did see them. So again, I also want to stipulate that this may differ from your state inclusion criteria. So you may have to capture two sets of data points, one for the state and one for ACS. Same question about isolated wrist or ankle fracture. This is interesting. I don't get a lot of questions about this, but I thought it was good to add in here. This is going to be the same as your non-surgical admits, your elderly falls, if you will. So the admission policy is going to be set by the trauma center. There's differences, as you may know, about the high-speed motor vehicle car accident with a negative workup, and then an actual that has an ankle fracture versus a truly isolated injury to the foot or ankle. So again, you're going to set that policy on how that's going to be admitted and who's going to see those patients. One of the options would be for orthopedics to be the initial consult. They could be admitted to surgery through trauma service with an orthopedic consult, or they could be admitted to orthopedics with maybe a podiatrist consult. So again, you're going to determine that at your trauma facility. Couple of questions. I've had several questions about the organizational reporting structure for a trauma center. The question here is asking, what are the reporting requirements for the program manager that applies to organizational structure? So there's a couple of slides I have in here, and they're just examples of what we like to see, or just examples that may work at your trauma center. We're not saying that this is how it should be, but they're just examples to see if that's what your trauma center will have. So what the ACS is looking to see is that the reporting structure allows the trauma medical director and the trauma program managers the ability to run their program, and their reporting structure allows them to address issues across the spectrum of the hospital. So again, there's a couple of slides in here that talks about how the reporting structure falls. So you have your VP of clinical operations, your service line director, and then you have your chair, trauma medical director, trauma program manager, and then your trauma program, your trauma PI nurse, injury prevention coordinator, and then your registrars. And again, there's no finite delineation about this. This can be, there's this example, and then there's a little different example here for level 1 trauma centers. Again, with your VP and your service line director being in line with your chair, your trauma medical director, and then following your trauma program manager. So I have a couple examples again for level 1, for level 2, and then your level 3s. Again, these are just purely examples. They're not in the book, but you're free to use these examples for your trauma center. I know Tammy talked a little bit about the ICD-10 codes and how they're impacting the registry. And this question is asking how we're integrating that with our PRQ. So for verification purposes, the trauma center should follow the National Trauma Data Standards Dictionary for Patient Inclusion Criteria, which can be found at the NCDS Dictionary webpage. So it's going to differ a little from the ICD-9, and here's an example. So go ahead and refer to that in the NCDS. So I can't get into very specifics of what that is. Again, there's a lot of information that is found in the NCDS data dictionary that you can refer to. Lately, a lot of questions about locum. I know that this is primarily for a level 2, and this is no different for a level 1 or 2 or level 3 trauma center or a combined trauma center. The locum emergency physicians have to maintain the same credentialing and education as our primary EM physician. And again, let me just stress that this is going to be applicable to your level 1, 2, and 3 trauma centers and any specialty surgeon or physician that needs to meet requirements. All trauma centers who have locums treating trauma patients must meet the credentialing process and same standards as the other physicians or surgeons. That includes board certification, CME for level 1, level 2, or through an internal education process, peer review attendance. All of that is going to be applicable to your locums, regardless of the frequency of trauma call that they take at your trauma center. So we're going to move on to CD-related questions. So I had a question about continuous rotation. Is there a requirement to have PGY 1 or greater in health overnight for a level 1 pediatric trauma center to be verified? No, there's no requirement for PGY in health overnight. To clarify, you may have a PGY 4 or 5 who is part of the trauma team that may begin resuscitation while waiting for the arrival of your attending surgeon. Again, this is in the book under CD 2-6. Your PGY 4 or 5 cannot substitute for your attending surgeon, and that is meeting the 15-minute response time or the 30-minute response time for level 3. Question about bypass/diversion. We use those words interchangeably. Question is, what is expected in a bypass protocol? And again, you can refer to page 25 for more information that I have here, but I've just highlighted some important things to have. One of the things is to have your trauma surgeon involved in the decision process. That's a requirement. Because someone did ask, someone submitted a question whether or not your trauma surgeon had to be involved in the process, and the answer is yes, it's a requirement. Second bullet, identify when the hospital's resources are not available or event of an internal hospital disaster. So I don't know if you can, if you have equipment that's malfunctioning or not working, that will definitely trigger your bypass, your diversion policy. And if should that happen, you need to notify your EMS agency and your hospital personnel that that you're diverting patients. You need to keep people informed of the status, and let any other trauma centers in your region know that you're diverting trauma patients, and keep them advised of the status. One of the other CDs associated with bypass/diversion is reviewing those occurrences and how often your trauma center is on diversion. It has to be less than 5% of the time, and that's CD 3-6. Again, here's that question someone had asked, whether or not the trauma surgeons notify when going to the on-ER bypass and not involved with decision to close every time. This is not acceptable. The trauma surgeon has to be involved in the decision process. Again, that's CD 3-5. Just to touch on transfers, CD 4-3, trauma transfers. Does the trauma medical director only need to review for appropriateness of transfer, or do we need to follow up with transfer center? So again, there's a lot more detailed information in the book about this, but all transfers need to be reviewed for appropriateness by the trauma medical director and the trauma program manager. The receiving facility should provide you feedback. If you're the transferring center, should provide you feedback to the transfer facility regarding the patient's condition, plan of care, and any PIPS issues identified. So that should be coming back to you, and document that in your PI process. Trauma medical director, does the trauma medical director have to be full-time? Again, I've been seeing this come up quite often, and this is from a level 3, but this is going to be true for a level 1, level 2. So in response to that question, the trauma medical director must be dedicated to one trauma center. He cannot administer 2 trauma centers, and the position must be full-time and permanent. So ideally, we don't want to see a trauma medical director, being the trauma medical director at Center A and then across town, they're also just noted or identified as the trauma medical director for that facility. That is definitely not acceptable in our process. It has to be, the trauma medical director has to be dedicated to one trauma center in that role. Trauma surgeon backup call schedule. If the trauma surgeon's on call as a backup, never the primary call, are they still required to meet the CME requirements? In response to this particular question, we do not have requirements for the backup trauma surgeons, so they are not required to meet the same standards as your other panel members, that being CME requirements or attendance at the peer review. If they're not your primary call physician. Trauma medical director membership, had a question about how do we define membership, active participation in regional or national trauma organization. The trauma medical director must be a member and actively participate in regional state symposium or national trauma conferences. Again, that's like AAST, East, even the American College of Surgeons, the ACS, for example. And this is just an example. I use Dr. Maxson. I think he was just easy for me to use here. Let's just take him as he's a fellow of the American College of Surgeons, so that's his membership, and he's also an active member on the Committee on Trauma, so that's his participation in our national conference. So that's just one example. So there's various other examples, but that's just an easy one to kind of paint the picture. Question about OPPE, how in depth or not should it be, and what examples? We do have some examples on the website. It's in the resources repository website. The expectation is that the trauma medical director conduct an OPPE and has a process. And again, the process or the documentation is going to depend on the trauma center. So it could be a scorecard, some kind of template, some kind of report. And it has, just have that available on site for the reviewers in case they ask. Some reviewers ask for it, some don't. So the depth of it is going to vary by trauma center. So it should include the surgeon's performance activities. That may include the attendance to peer review. It could include CME tracking, any corrective action review that a physician has gone through. And I think there was a follow-up question to this. Someone had asked if it can be integrated. Here we go. It can be integrated with their hospital's internal OPPE, and yes, it can. It doesn't have to be separate. They can integrate it with the hospital's OPPE as long as the trauma medical director has some oversight in that process. So, and I also want to state that the trauma medical director is not expected to review or to perform, I apologize. TMD is not expected to perform an OPPE on all specialists, just for his service, that being his trauma surgeons and any advanced practice providers that are reporting to that service, or under that service rather. Every other service should have its chair or director, if you will, perform an OPPE, but the TMD should have oversight over all those occurrences. Question about limited tier response, C516. Is the expectation from this criteria that the trauma surgeon comes to the ED on Tier 2 activations within a specified time, or rather within a specified time frame when admitted to the hospital? So the expectation is for the limited tier team activation, time expectation for the types of injuries, the patients the surgeon will respond to would be determined by the institution. It would be based from when the ED activation was called. So again, it's going to be defined by your trauma center, and it should definitely probably be defined from the ED activation when it was called. Question about alternate pathway, CD6-3. So we've had a lot of folks go through the alternate pathway process. I won't spend a lot of time on this because it can get a little in-depth. We do have some information on our webpage and in the repository section of our webpage. But the question here is, Trauma Center has a non-U.S. boarded neurosurgeon taking trauma call. How long must he follow the alternate pathway criteria? Great question. So let me clarify, because I don't know a lot of the background about this particular trauma center or where this question is coming from, because there's always more questions about the alternate pathway than one knows about. So let me clarify. All surgeons who are non-U.S. or Canadian board certified who are or will be participating on trauma call must be reviewed by the alternate pathway criteria at the current institution that they're employed at. Again, there's information on the repository website about that. If they have previously been approved by the way of the alternate pathway at that facility, the following slide is going to outline what is going to be required. So going back to this person's question, how long must she follow the alternate pathway criteria? Well, It's going to depend. So if this surgeon, this neurosurgeon, or any other surgeon for that matter, is taking trauma call at your facility and they are there during the reporting year, the expectation is that they're meeting the requirements for that period. So again, there's a list. You know, they have to meet CME, they have to meet peer review attendance, they have to attend national conferences, regional conferences. There's attendance related to that. So I don't think they can do that in a matter of 6 months. So the expectation is that they're doing that during the reporting year, if not longer. So keep that in mind. So let me go to the next slide. This is for surgeons who previously been approved through the alternate pathway. An on-site visit will not be required. Again, let me stress that if they were approved or reviewed by the alternate pathway at your facility, they would not need to have an on-site visit. What will be required is the following: a list of the 48 hours of trauma-related CME during the past 3 years. That could be met with external trauma CME or internal education. Documentation, surgeons present at least 50% of the trauma peer review meetings, membership attendance at local, regional, or national trauma committee meetings, and the PIPS performance reviewed by the trauma medical director. So these are the 4 elements that we're asking those who've gone through the process before. So this is very similar to the other members on the trauma panel. Question from a level 3 at a neurosurgery. Please define the CDs that need to be met for level 3 trauma centers with neurosurgery capabilities, other than the ones already established. There are no additional requirements for this. So at this time, those level 3 trauma centers that do have neurosurgery capabilities, please follow the established requirements that are in Chapter 8. Those are the ones that we're going to hold a trauma center at a site visit. We're not asking for any additional requirements to be met. Excuse me. Neurosurgery contingency plan, again, this is in the book. You can refer to Chapter 8. Can you describe appropriate neurosurgical plans for real programs as identified in CD 8-4 and CD 8-5? ACS does not differentiate rural versus urban, so there's really no difference for our process. Whether you're in a rural setting or an urban setting, the requirements are going to be the same. So please refer to CD 8-5 in the book for level 1 and level 2 trauma centers. This is what the question is related to. So the contingency plan should have a published backup cost schedule. It doesn't have to be, so your published backup cost schedule, you can have that, or you can have this contingency plan, have a diversion plan, meaning your primary backup neurosurgeon is encumbered, EMS notification of diversion, what your process is for that, and you're going to review each occurrence or each instance that you are using the contingency plan. So there's a couple of things that you can do for a contingency plan. Again, it's outlined in Chapter, I think it's in Chapter 8, definitely in Chapter 8 and also in Chapter 16 as well. Can you please clarify if a neurosurgery, orthopedic, NPPA can respond within a 30-minute window for specific criteria? So I'm going to assume this is for the consult level. If the trauma surgeon or attending, the trauma attending asks for a specialty consult. So it is acceptable if there are agreed upon guidelines between the trauma medical director and the neurosurgeon and or orthopedic liaison for the types of injuries the resident or physician assistant will respond to. If that is the case, there must be clear documentation with the attending specialist surgeon on the plan of care, so make sure that's documented. Just not a hallway conversation, it's got to be documented. I mean, we've seen a lot of this occur just in passing, but it's got to be documented. Question about operating room availability. What is an effective TIPS process to monitor that an OR is always immediately available? Assure there are policies and procedures established to adequately review and measure the outcomes outcomes relative to this requirement. So a couple of examples are that there are adequate OR rooms during the various times throughout the day, so that if there's an emergency, a case can get bumped. Make sure there's a process in place for that. Have audit filters to track delays and notifications. Surveillance reports that show periodic analysis and rate trending. So you can run all types of kind of reports on how this works at your trauma center. There's no one established process. Again, whatever works at your trauma center is going to be acceptable as long as it's being reviewed through your PIPS process. Operating room availability. What time are most level 3 trauma centers using to start the clock ticking for the 30 minutes to OR for emergent cases, the CD9-2. So the question came about whether the clock starts when decision of need for the OR or the ED arrival time, CT read time. I think there's various, and I think there was a couple of questions in our slide deck about this. And the best answer I could give is the clock starts from the time the OR is notified a case needs to be done. So as soon as the attending or whomever is going to make the call makes notification in the OR that the patient's going to go to the OR, that's when the clock starts ticking. And there's also, this is also stated in the clarification document. Question about radiology interpretation rates, whether is there a recommended X-ray discrepancy rate for films which are read initially by a non-radiologist? No, we don't have any discrepancy rates for the films. We do ask about it, but we don't have a requirement based on this. The radiology report can be highly variable. The expectation is that the changes in interpretation and missed injuries are monitored through the PIPS process, and that could be through radiology PIPS process, and then have them report that to trauma peer review or to the trauma PIPS process. The radiology department should have a systematic process for monitoring revisions and missed injuries. ICU coverage, question about, is this referring to the trauma surgeon? Should this measure be tracked? If so, in what instances? So we have requirements around this. So there must be an appropriately trained physician available in-house within 15 minutes to provide care for the ICU patient 24 hours a day. This must be tracked, and it does need to be monitored, or documented rather. The coverage may be performed by an appropriately supervised senior resident or an in-house trauma attending credentialed to provide critical care. So, you know, an example would be a patient who just recently came out of the OR and has severe bleeding, or you know, needs to be resuscitated. Those are the kind of emergency the response times that we want to see the 15 minutes tracked and monitored. ICU director, can the surgical director of the ICU be an informal role? Does it need to be a job description and formal appointment? So I've had a couple of questions about this. So when we talk about liaison, we do want to talk, or director, we do want it to be formal. So it has to be something documented that that's going to be the liaison or your director, meaning that the ICU director must meet the qualifications. So there's, again, if it's formal, or I should say it must be formal, they are required to meet the qualifications, i.e. board certified general surgeons, CME, peer review attendants, etc. The expectation is that the ICU director must be involved in the care of the trauma patient. Similar question, and this is about the co-director, whether or not it has to be formally written for a level 3 trauma center, or can it be understood and monthly communication shown between trauma centers. So I'm assuming it's the same question, or alluding to the same question as the one prior. There must be a formal process that whoever is going to be assigned as the co-director or director, it must be a surgeon, and that they are actively involved and meet the requirements stipulated for level 3 trauma center, Again, this actually CD 11-53 applies to level 2 and level 3. So the ICU co-director or director must be actively involved and responsible for setting policies and administrative decisions related to a trauma ICU patient. ICU credential providers, is subspecialist arrival time tracking necessary for those patients who are not considered emergent urgent? So I didn't want to say no to this because really the requirement is for the trauma program to track the time the trauma surgeon or consultant, i.e. subspecialist, was page called to the ICU for emergent issues. So we're looking for those emergent issues related to the trauma patient, and those emergent issues should be documented and their response times tracked at bedside. So any issues resulting from delays must be reviewed through the PIPS process. Peer review meeting, ICU liaison. Another great question, I get this often. Does the ICU rep, meaning the ICU representative, and this can be for any service that needs to meet the trauma peer review attendance, so not just for ICU, but it could be for ED, trauma surgery, neuro, ortho, etc. It does have to be a physician or surgeon. All peer review attendees, excluding the trauma program manager, and in some cases the PI coordinator, must be surgeons or physicians who attend those meetings. There's an attendance requirement for them. So if it's the rep or if it's the liaison, they must meet 50% of the time, and they must be the physician. So you can't send your PA or your advanced providers to those meetings to meet the attendance requirement. Question about microvascular. Is a level 2 required to have 24/7 coverage for hand surgery? And what is the expectation for microvascular surgery? Does the surgeon need to do free flaps and trams? Will transfer agreements suffice for a level 2 for intermittent coverage? So a level 2 trauma center must have hand coverage and microvascular coverage. We're asking for example, for microvascular coverage, that may be satisfied by a surgeon who uses an operating microscope for nerve repair, free tissue transfer, etc. So there has to be, so if you don't have a microvascular surgeon, it could be met by a surgeon who's skilled or capable of managing a microscope for nerve repair, etc. Same goes with hand surgeon. These specialists are not required to be in-house 24/7, but must be available to consult in person when requested by the attending surgeon. So it can't be done by phone, it can't be done by telemedicine, they have to be in person. Again, they don't have to be in-house 24/7. They can see the patients the next day, but all that has to be documented. There may be transfer agreements for complex injuries, and those are outlined in Chapter 11 under CD 1171. Questions about advanced providers needing ATLS. Again, this is in the clarification document, and we've talked about it over a couple of other webinars. The question is, the PAs or advanced providers who are not involved in the trauma team activation are not required to be current in ATLS. We're looking for those advanced providers who are part of the trauma team activation and who have hands-on with the trauma patient, the resuscitation, evaluation of the patient. They have to be current. Benchmarking question, where is the risk-adjusted benchmarking template that is marked as pending on the PRQ website? You know, that is actually going to be revised. We are going to make a change to that list with the new change in the CD 15-5, where effective January 1st, 2017, all trauma centers must be enrolled in TQIP. The benchmarking template is no longer necessary, so we're going to go ahead and update that on the webpage. Question about registrar. Is there any talk about moving the charge per registrar from 500-750 to 500? As Tammy talked about a little bit early on, at this time there are no revisions to decrease the number of cases, but as she talked about, and myself, you know, go ahead and visit the stakeholder public comment website to provide feedback on that. standard or any other standards, that is, as she mentioned, that's going to probably be the second chapter we're going to review for revision. So go ahead and provide some feedback on that. Question about, do all hospice cases have to be presented in monthly trauma M&M or just a case review? Yes. If the death occurred while under hospice care at your facility, that case must be reviewed. If the patient is transferred to another facility or a hospice care facility, those cases will not be reviewed under your death, under your mortality review, that is. Do all death cases need committee M&M review, or can they be vetted by the trauma medical director and trauma program manager if there are no issues? Not all death case reviews need to go to M&M. Deaths with opportunity must undergo review. So any that you identify with opportunity for improvement, those should definitely be reviewed. Question about multidisciplinary operations meeting. Can it be held as often as you want with no physician attendance requirements? So great question. So the Trauma Systems Operation Committee may be held as often as deemed necessary. The manual states it should be held quarterly with physicians, pre-hospital personnel, nurses, technicians, administrators, or any other personnel. So this, again, is going to be defined by the Trauma Center, but it should definitely be held quarterly. But if you need it to happen or occur often, you're free to do so. Prevention activities, what are they looking for in a fall prevention program for elderly? How have other facilities handled this? So for level 1, 2 trauma centers, ideally you want to use your trauma registry to drive your injury prevention activity. Again, there's more information on this in Chapter 18 on how and what we're looking for. But the program and intervention strategy should then be selected based on the data. So for an example, here's an example. So let me back up a little bit. So use your registry to determine what your injury prevention is going to be. So for example, if it's going to be your elderly population, an example would be going out to venues or to conferences or regional events in your state and provide education to senior citizens on preventing falls and risk factors and anything associated with that. So there's a couple of more examples. You can reach out to me if you need more. Prevention program partnership, what types of community organizations are acceptable to partner with? Again, there's a listing on page 141. So you can partner up with law enforcement, schools, churches, county health departments, and any other organizations. And it can include any other trauma centers in your region or consortium. So you can really partnership with anyone in that matter. Pediatric CME. If adult trauma surgeons are caring for pediatric trauma patients, do they have to demonstrate pediatric trauma education? No. Ideally, we would like to see them have some pediatric education, but there is no requirement. The CME pediatric requirement is for level 1 or level 2 pediatric trauma centers that are seeking verification. So that's what we're looking for at this time. So I would like to thank everyone for listening to today's webinar. And I do want to clarify that our next webinar is scheduled for March 30th. And we will go ahead and send everyone an email. So thank you again for participating.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification February Q&A Web Conference. If you have any other questions, please contact cotvrc@facs.org. And on behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.